It's really great being with you today. We are going to be talking about tuberculosis. It's something that we should be talking about a lot more, actually. But this conversation brought to you by Brimstone Investment Corporation Limited and Groote Schuur Hospital. And the reason why I say that we should be talking about this a lot more, just imagine this for a second, right? Imagine a plane crashed every day in South Africa, and everybody on board that plane was killed. How do you think the newspapers would deal with it? How do you think the radio stations would deal with it? How do you think the television stations would deal with it? The cameras would be all over the place. They'd be telling personal stories about the people who died. Whose fault was it? Was it pilot error? Was it the company that didn't build the right type of aircraft? And it would be news for days, not just in South Africa, but internationally. What would you say if I told you similar amounts of people die each and every day in this country, and nobody, very few people, actually talk about it? So as a retired media person, a person who also loves healthcare and the good work being done within the healthcare sector, for me, it's a travesty of justice, which is why I'm so happy we're actually having this conversation today. I'm going to introduce you to the panel. I've got a whole lot of stats in front of me. I'm not going to run through it. I'm actually going to get our experts to talk about it. This is about telling the story of tuberculosis. It's about telling the story of the challenge. It's about telling the story of first-hand experience, so that you can be empowered at the end of it. So, Professor Keertan Dheda. Now, Prof. Dheda is the head of pulmonology at UCT, as well as Groote Schuur. Pleasure having you on the panel.
Thanks, Kieno.
We also have Dr. Lenny Naidoo, who's the senior medical officer at the City of Cape Town. Good to have you on.
Thank you.
Then I've got Phumeza Tisile, TB survivor.
Yes.
Thank you very much. Not easy telling personal stories, so I really appreciate the fact that you're here with us today, as well as Goodman Makanda, also TB survivor. Goodman, thank you very much.
Thank you.
Great. But let's hop straight into it. We talk about tuberculosis. Prof. Dheda, let's start with you. What are the things we should know about TB that people don't know? Some of the worrying numbers that you guys have to grapple with on a daily basis.
Yeah, thanks, Kieno. I think that's a very good point. The bottom line is we have a massive burden of TB in this country. The numbers are quite staggering, and roughly this equates to about 400,000 newly ill people with tuberculosis every year in South Africa, and roughly 60,000 deaths per year. And TB, up to this point, has been the most common cause of death officially in the country for many, many years. And if that wasn't enough, we also have a problem of drug-resistant TB. So roughly about 6% of all the TB cases tested turn out to have drug-resistant TB.
Oh.
And this type of TB is much more difficult to treat, has a higher mortality. And even more worrying about these numbers, it's one thing, the burden of TB, but there are two other important statistics. One is the so-called missing cases. And what that refers to are people that are undiagnosed or undetected. So it's one thing having 400,000 newly ill people with TB every year and 60,000 deaths, but about 150,000, maybe more of these cases remain undiagnosed or undetected. And that is really staggering. And with the advent of COVID-19 and reduced case detection, the number of missing cases has jumped. Now, this is not only a South African problem, it's a problem throughout the world.
Right.
And the staggering statistic is that 4 million out of the 10 million newly ill people with TB in the world remain undiagnosed or undetected. And I think the other thing just to mention, we always obviously talk about people and death and suffering, but there are two other dimensions to this issue that I think are really important to mention. Mm-hmm. The first is the damage after TB.
Yes.
And it's a very important cause of lung damage and chronic disability, recurrent chest infections, and a whole bunch of things. And we don't talk about that. And the other thing is the cost to the country. And we can talk about that later, but it's estimated that TB impacts our GDP by about 2 to 3%. In fact, we don't have a good idea what this disease costs the country. And that equates to roughly, the last time I worked out the numbers, was something close to 200 billion rand a year, which is more than our entire health spend. So, from a political point of view, from a socio-economic point of view, we should be putting a lot more resources into fighting TB because it's the right thing to do, but it also makes a lot of economic sense. And we don't often think about it in that way. So I think I'll stop there just in terms of sort of the headline figures and numbers.
Very important to grapple with those. And I'm just thinking about the numbers that you mentioned in relation to GDP. I mean, imagine we spent 10% of that and invested that in dealing with some of the challenges that you've just highlighted. But it is something that needs to be taken more seriously, which is why I'm very happy that we're having this conversation today. So, Dr. Lenny Naidoo, at the City of Cape Town, the coalface of what's happening out there, we've heard the numbers and that Professor Dheda has mentioned. What is your experience with that on the ground?
Thanks for the question. So I must agree with all Prof. Dheda's points in terms of TB and the amount of resources allocated to TB versus COVID. I think for us on the ground, we saw this dramatic drop, like over less than 50% than what we'd previously seen, just in terms of diagnosis. So patients, I think initially that fear of COVID were not coming to the clinics, so that's one thing, and staff were getting infected, so there was a fear of patients getting infected. Obviously the lockdown, the extreme lockdown levels affected people's, livelihoods, loss of jobs, income, so they weren't able to travel, transport. So lots of these things, so a lot of factors, but I think also we forget the mental health impact of COVID as well. Yeah. I think that's an overarching thing, that's one of the most severe impacts, both on the community and staff, and that doesn't get addressed. And so people were scared to come. Although our clinics, we sort of de-escalated services, but we kept our clinics open, like for things like TB, HIV, child health services. But we didn't want patients on treatment to come like they used to come daily for treatment. We said, no, let's give you a week's treatment or a month's treatment because of the risk. But what we thought, like what Keertan mentioned as well, that initially maybe the patients were coming for screening. We screened everyone that came for COVID, but how many of those patients actually may have had TB, but we focused too much on COVID and they missed opportunities for actually diagnosing TB. We think that's one of the big things. And we sort of addressed it now. We've got a screening tool that screens both for TB and COVID, but until now, we haven't seen that rise. Very worrying. There's missing cases like Keertan mentioned. Where are they? The question is, are they ill? Are they dying at home? Why are they not presenting? Shouldn't we, as the health system, look at other innovative ways? Shouldn't we be going to patients' homes and communities and testing them at home, treating them at home? So so very worrying.
So if we talk about the missing patients, right? I mean, there are a couple of things here. So my head's spinning at the moment. I'm trying to figure out which one to do first. As a matter of fact, I think it's important for us to talk about when you can actually spread it. So you might be asymptomatic, or you might feel like there's a bit of a problem, but you don't know what it is and you just go on with life. And you've got in South Africa, 150,000 missing TB patients. Let's talk a little bit about people who are asymptomatic and the 150,000 missing patients and what that means for an increasing rate on a yearly basis if it's not arrested.
So I think that's a critical question. And I think the first thing to say that there was a national survey carried out in South Africa in 2018, 2019. And there were interesting findings of that survey. This was a door-to-door survey where they went to different districts in the country and tested everyone for TB, whether they were symptomatic or not. And there were two key findings. The first was that we were underestimating the burden of TB. It was much higher than we thought. But the second very interesting finding was that just under 60% of the diagnosed cases from the sputum samples that they took were people that didn't have significant symptoms or didn't consider themselves to have significant symptoms. So they were what we would describe as asymptomatic. Right. And that really speaks to our current strategy. Our public health strategy needs correction for TB. The current strategy is one that we call passive case finding. And that means we wait for people to self-report to our clinics and hospital. Now, that doesn't make any sense if 60% of them don't have symptoms that they consider significant, right?
Exactly.
What we really need, especially with COVID-19 and the reduced detection, is a different paradigm where we move diagnostic strategies and perhaps even tests out of our healthcare facilities and into the community.
Yeah.
So we need to actually go out into the community and find these cases. And we call that active case finding. So we need a big change in mindset. And, you know, we've learned from COVID-19. There are many tools that we have. We have screening apps.
Yeah.
We used it very successfully for COVID. They're dashboards, right? We know all the time how many people are. It's on the news every day. How many cases, how many deaths. We don't have that for TB. Yet this is, you know, been killing millions of people in South Africa for many years. And then the next thing is, you know, to have innovative ways of getting people who have any sort of symptoms to then come in for testing. But we also need to take tests out to the people.
Yes.
And that may involve community health workers and healthcare staff going into communities to actively screen people. And there are many different models and innovative tools that one can use. So one, for example, that we developed at UCT and Groote Schuur Hospital is called Exact.
Yes.
And it's expert for active case finding. And we've taken the portable diagnostic testing machines.
Right.
So our frontline test in South Africa is to detect DNA of TB in spit samples. And now we don't need generators and things. They are small battery-operated devices. Mm-hmm. And we can put these in the back of, a small minivan like a Toyota Avanza or a Nissan.
Right.
So these are scalable things we do. This is not, millions of rands for a truck with a mobile lab and all that type of thing on.
Yep.
This is something scalable. It's much more low cost, 1 or 2 healthcare workers, and a similar strategy that's being used to vaccinate for COVID-19, right? The pop-up vaccine, a similar model. So, it's not one magic bullet. It's a whole range of things from screening apps to dashboards to going out into communities, but changing the whole paradigm now to going to find actively the missing cases. And I think that is the critical thing.
There's a perception, just sticking to the whole issue of the missing cases. People are saying, it's people in rural South Africa who don't have access to the hospitals, et cetera, et cetera. But that's not the case. I mean, if one looks at those TB, the numbers, they're right here in urban South Africa. So would either of you, Prof, Doc, would you like to extrapolate on that? In terms of in the city of Cape Town, for example.
So you see our highest burden in the city of Cape Town, Khayelitsha, I think one of the highest in the world, actually. So it's informal settlements, peri-urban areas,
Yes.
So the socioeconomic conditions, so it doesn't have to be in the rural area. So that's a misconception. So very high TB incidence in the city of Cape Town. And most of our sub-districts have got informal settlements, and that's where we find the highest burden. So it's, again, social determinants, socioeconomic factors, closely related.
Yeah. But close to where the medical facilities are.
Exactly. No,
I mean, Khayelitsha's got probably one of the best hospitals.
Yeah.
I always said if anything ever happened to me and I need to go to an emergency unit, then take me through to that one, please. Right.
And we have to add, we have city clinics throughout.
City clinics, exactly.
Multiple throughout the areas. Yeah.
Exactly. So the strategies that you talk about, to me now seem like no-brainers, right? But it's something you guys have developed. Are you finding that you're getting the support for this, though, at the right level?
Well, at the moment, the testing strategy and the public health strategy hasn't changed. There's some light at the end of the tunnel in the sense that some things have happened. There is a TB screening app. It is available through the Department of Health, but it really needs to be scaled up and made more popular. Most people don't know about it. And we need to ask ourselves, how do we do that? We did it for COVID-19. There is also a TB dashboard that the Western Cape province has launched. It's live. You can go to it and it's like the COVID-19 dashboard. It tells you how many cases, how many deaths. But we need a national one. And I would suggest every time we should show the COVID dashboard, we should show the TB dashboard.
Yeah.
And probably why not add the HIV dashboard, because those are the three intersecting pandemics that we face. This is, we're not just facing COVID-19.
Yeah.
We're facing three pandemics.
Indeed.
And and then there are some districts in Cape Town where this model has been implemented, where they've sent out community health workers to homes, door to door, to collect samples. So there's some things happening, but the official strategy hasn't changed. This needs to be massively scaled up. And, that's what we need to do. It's about knowledge translation.
Absolutely.
We know what needs to be done, but the question is, how do we do it now? And how do we implement this and take it forward?
You just need a bit of leadership. Someone saying, well, this is important. Let me say something which might sound a bit controversial, but let me say it nonetheless. COVID-19, when it first came out, we all saw the memes, right? It's only people with budget who get it. These are the people who were flying and came in from wherever. It affects, and this might be the wrong perception, but it affects everybody. Whereas TB does not necessarily affect the richest in South Africa to the extent that COVID-19 does. And like with most things, let's call a spade, unless the richest, the taxpayers, everybody's a taxpayer, by the way, gets affected, it does not seem to get the type of support. TB's been around for how long? With COVID, we've got businesses, big businesses from across South Africa coming together, going, we're going to fight the pandemic. Where were they over the last couple of years when people were dying of tuberculosis in our country on the doorstep? So I don't know, some comments from any one of you around that. Is it because COVID-19 seems to affect everybody, it's at everybody's doorstep, that it seems to be getting the love? And when I say the love, I'm talking about the attention for vaccines and everything else. What's your take on that?
I share your sentiments. For me, that's one of the things. It's just because I'm working in TB for close to 30 years, and the passion for TB. Initially, when COVID came, I was one of the skeptics, but I understand the public health, reason, for all. But I've never seen the scale where people come together, even in the Western Cape, where there's academics, researchers, government officials, for something new that we know nothing about and we learn daily, but where people work together and came up with all these innovations, it's just amazing. And worldwide, to get 7 or 8 vaccines in less than a year, it showed the technology is there. Yeah. But because it affected the richer countries, the funding came. That's where the big gap is. TB and HIV, there's no funding. So because it affected both the rich and the poor, so that's where all the funding, the vaccine, the science, and so everyone worked together. And to see this collaboration, multi-sectorial, so why not the same for TB, And use, like Keertan said, the same innovations, the dashboards. Yeah. We have a call center in Western Cape that calls every single, a case that's diagnosed or their contact. So why can't we do the same for TB? We got this group that calls every diabetic with COVID. So why can't we call every patient that has TB with diabetes? There's so many different innovations, but I think there's lots of plans and talks, but we're not seeing action. So really, so that point of yours, I strongly agree, Not getting the same response because it affects the disadvantaged and the poorer community.
Yeah, so it's highly frustrating.
I think to add to the point that Lenny made about, affecting the socioeconomically disadvantaged to a much greater extent when it comes to TB, I think that is clear. So the other thing to say is that, TB is a slow killer, kills over months and years, whereas COVID-19 kills over days. And COVID-19 also is an acute event, and, the infection occurs in waves, and we have our hospitals filled to capacity, people waiting for beds, dying outside hospitals.
Yes.
So there's also that aspect.
Yes.
But, that needs to be made clear that at the end of the day, it's not a competition of deaths between two diseases, but the presentation of one disease is much more dramatic from a public health perspective. But that's the message we need to get across. It's the number of people that are dying. It's the chronic disability. It's the economic impact. And, if you look at that impact over, say, the last 10 years, again, this is not a competition of diseases and deaths, but the impact from TB has been far greater. And I certainly think that we haven't got a good idea of the economic costs. These are only estimates, done by external entities, global agencies. We don't know as a country what this disease is costing us. And I think if we understood that dimension, it would add a lot of political clout, and the Treasury, being obligated to put budgets towards fighting TB, then it becomes a no-brainer. So I think we need a lot more of this kind of understanding.
Without a doubt. Now, we've had a bit of a high level around TB, etc., but I want to get more granular now. Personal experiences. So, Phumeza, let's start with you. Tell me about the day you were diagnosed with tuberculosis.
Well, that was not easy, actually, to get the diagnosis. At the time, I was a first-year student at CPUT, right? So I didn't have the obvious TB symptoms like coughing or sweating, but I would get tired easily, and I also was getting thinner, which is I was losing weight. So I went to the private doctor, and then the doctor checked for all common diseases. They all came back negative, meaning there was nothing wrong with me. But then they gave me some pain medication, not sure why. But anyway, I went home again, but then I had to go back to the doctor because now it was really, really hard for me to walk. I was having shortness of breath. And then he saw that I was really sick, and then he said that because they do not test for TB with the private doctors, I must go to the public clinic to get a TB test. So I went to the clinic, and at the time I had to cough out sputum and then wait for 3 weeks. By the time I was worse. The results came back, didn't show any signs of TB. So they were assuming pneumonia, they were talking among themselves, but I was very sick to even pay attention. But then one doctor said, okay, you know what, just go to a chest x-ray. And then I was diagnosed through a chest x-ray because apparently it's supposed to be dark, but mine had spots that were I could see their face, look like, wow, you are really, really sick, you have TB, that's what they said. And I was like, okay, fine, I have TB, I know TB, 6 months I'll be fine. They're like, we'll see. But then they give me those 3 tablets, huge TB tablets. I call them normal TB tablets. They were easy, but I was not getting better. I was getting worse. And then the next thing I know, I woke up in hospital and they had to test again. And then the results again came. Then it was a different kind of TB they said I had MDR TB.
Yes.
I had no idea what they were talking about. I know TB for 6 months you get well. Now MDR, multi-drug resistant TB, they tried to break it out to me. They tried to explain that I need to take 25 tablets a day with an injection every day for 6 months. So the treatment will be 2 years, the injection will be 6 months. Now imagine getting injected every day for 6 months. That was the darkest, most confusing because I didn't know MDR, I didn't know XDR, I didn't know there was drug-resistant TB. And then now I was being told now that I have to take these tablets for 2 years. I can't go back to hospital. I can't go back to school. I have to go be hospitalized. It was a lot. And then, the tablets, they're so toxic that you are bound to vomit like every morning. But you have to take them because you want to survive. And then 4 months while I was on treatment, and I woke up in the hospital. Something was different this day. I woke up, went to the bathroom. I was flushing, there was no sound. Opened the tap, there was no sound. I was like, maybe I'm still dreaming. This can't be true. So I thought there was something stuck in my ears,
Right.
So I took those ear cleaning thingies. Still, there was no sound. And then, the nurse came at the ward. And then I told her that I can't hear. And then I couldn't hear myself. Very confusing. And then she was saying something. I know this because her lips were moving, but there was no sound coming out. So she saw my confusion and she took out a pen and paper, wrote down that I must go to the audio department it was at Brooklyn Chest Hospital. And then the audiologist ran all those tests with big earphones. They were playing some sounds. I could hear some, I could not hear some. And then they just wrote deaf capital letters on my forehead. I was like, what is happening? You know, I was sick, TB. Now you're telling me I'm deaf, and then I was told to go to the doctor. So now it was not a normal conversation like we are having now. The doctor was writing, was the one doing speaking. I could not even hear myself. Imagine how that must have felt for me.
Can't even.
So then she wrote, like, she was very patient. She wrote everything down. But the thing that stuck with me was that she was very, very sorry and that there's nothing that they can do. The hearing loss is not reversible. I'm actually deaf, like, forever, like, for life. It's not reversible. I was like, this can't be real. Maybe I'm in a movie, maybe I'm still dreaming, you know, like, what's going on?
Yes.
And then I was sent back. Now I was no longer MDR TB. Now they told me that it was pre-XDR TB, which is pre-extensively drug-resistant TB, like big words. And then I was changed from the MDR ward to the pre-XDR TB ward. And then I had to, do all those tests again. And then while they were doing the test, they saw something, they called it unusual, that was building up in my lungs. And I had a little lump here. So they were assuming a cancer, they were assuming some sort of a tumor, but it was neither of those. But then I was referred to Groote Schuur. And then it was just some liquid building up.
Yes.
They didn't explain why it was building up. I didn't ask because I was so tired. But then while they were doing the surgery, to take out that liquid, they broke my rib and my lung was punctured.
Oh,
Can't catch a break.
wow.
So anyway, I got better. I was sent back to hospital. I was gaining weight. Now I was better. Then I was discharged. I tried to go home with pre-XDR TB. So 9 months when I was hoping, like, you know what, this is it. I'm going to finish my treatment. I'm going to be fine. Then I was told that the pre-XDR TB drug stopped working. Now I have full-blown, extensively drug-resistant TB. And then at this point, I was told I have 20% chance of surviving this. And likely enough, at the time, there was a group called Doctors Without Borders, MSF. And then they told me that there is a drug, but this drug is out of reach. It's very expensive, but they're willing to buy me this drug. They gave me a choice whether I want to take this drug or not, meaning if I take this drug, there's a chance. If I don't take this drug, as Professor said, you die slowly. It doesn't happen fast. It can take months, can take years. It's up to you. Then I was like, you know what, I have nothing to lose. I took the drug and then it worked. I'm here now talking I got cured after 3 years and 8 months.
And your hearing?
Getting there. So I got cured after 3 years and 8 months. So I was Googling how to get your hearing back on Google. And then obviously there are all sort of things like you must put Dept, you must drink this. You can't get your hearing back that. But then I come across a thing called cochlear implants. There I saw the price, very expensive, 40,000 US dollars. That's like just over R500,000.
Yes.
So we did a crowdfunding, and within a month, I got all the money together because I was sharing my story. I was, blogging because awareness was needed. Someone had to know that there's XDR, there's MDR. So yes, I got my hearing back through cochlear implants in 2015. And I was able to go back to school. I was actually graduated at UCT 2020. So that's my story. But if I had to break it down, it's very, very long. So that's the summary of my story now.
Oh, but I mean, you look at, I can't imagine the lows that you must have gone through. One bit of bad news after the other, after the other.
And I was only 19. And, people were celebrating because the World Cup was here. It was in 2010, so the World Cup was here. I was not even into that because, you see people celebrating. You're like, I'm dying. There's nothing to celebrate here. So it was a really, 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 really hard time for me.
My word. What does one even say to that? And let me ask the doctors, because, Goodman, I want to hear your story as well. Very important, right? But, Dr. Naidoo, is this a 1 in a million case type of experience? Is this what a lot of people are going through? I know we were speaking about, I think, 6% I think the number was 6%. Yeah.
Yeah, so what Phumeza described is with the old regimens, that's what patients went through. It's a horrible treatment. It was 2 to 3 years taking an injection daily for 6 months, walking to the clinic and getting a soy injection that 40% chance you will get deaf, and also telling you that even if you take this treatment, you have a less than 50% chance of even getting cured. So imagine that, giving no hope even in the beginning. So that was happened before all the new drugs and the shorter regimens, 2 to 3 years, not even guaranteed of, and horrible side effects like vomiting, like you mentioned.
Yes.
The deafness was the serious one. About 40% of the patients became deaf, permanently deaf. So the treatment journey, that's why it was so important. Like as a healthcare worker, I mean, I've been working, for me, it's being kind, being caring, supportive to the patient, and trying to help them. It's a long treatment journey, not just writing a whole lot of tablets. And, it's not easy, because most of us, we know we won't take antibiotics for 7 days. We feel better, we stop it. But imagine taking it for 6 months, but 9 months, 2 years. Very difficult, long, toxic treatment with bad outcomes. And like Phumeza explained, she actually became deaf and luckily was able to get a cochlear implant. Yeah, so that's a reality. So I think a lot of people are not aware of this, and working with patients closely. So I think that compassion and caring and support from all parties is also important, because swallowing those tablets is not easy. Yeah.
Where are we now, though, with the latest regimens of drugs that we have? Prof. Dheda.
Yeah, I think, we also need to appreciate that we've done a lot in this country, and we have to credit the Department of Health and so many agencies in the country that have done a lot of good work. For example, the rollout of these DNA-based tests called Gene Expert. We're one of the few countries in the world where you can walk into any clinic and get this as a frontline test. That's not even the case in Europe, where incidentally there are big TB problems as well, especially in Eastern Europe. So it's not only a South African issue.
Yes.
So we've come a long way also in providing newer drugs. South Africa has been a lead in this respect in the world. And, what Phumeza describes at that time, she had to undergo treatment for almost 2 years.
Yes.
And we're now using regimens in this country where we're not using these toxic injectable drugs anymore. And we're using regimens that are closer to just about a year or under a year.
Okay.
And just to mention, because we just released this information at the World Union Conference at UCT, we did a seminal study where we've tried a regimen for 6 months. Mm-hmm. And we found that this worked very well, was much more effective than the traditional regimen. And this work will be published soon, but it has been released at the South African TB conference this year and at one of the global TB conferences. And so I think it won't be very long through this study, the next study, which was done through UCT at multiple sites in the country. But also there are a number of other trials globally that are attempting to shorten TB treatment. In fact, at the same conference, there were results released from another trial called TB Practical, using a different combination of drugs. But I think it won't be long, and Phumeza will be delighted to hear this, that we will have a 6-month regimen.
Are they
that will
toxic,
be
the drugs?
Well, no injectable drugs.
Well,
and
do they vomit?
Well, not to the extent of the previous regimen. There are some drugs like linezolid which do have some toxic side effects. Mm-hmm. So I think we obviously need to improve, but things are definitely getting better. But the other thing that I wanted to pick up on, which I think is a critical point, is, one layer is this huge burden of disease and drug-resistant TB. Another layer is the missing cases, the 150,000. But the big problem is, even if you were to go out, making a diagnosis, as Phumeza described, is a problem, right? How do you make a diagnosis? Because you need a spit sample. She couldn't produce sputum, or in the spit sample, the TB bug concentration is quite low. So a big challenge, once you drill down to actually getting out to people, is getting an effective way and a foolproof way to diagnose TB. And what we really need is a sputum independent test. In other words, we're not dependent on somebody producing sputum.
Yes.
You heard about the chest X-ray, and that's how they inferred the diagnosis. And it's interesting that of the total number of patients we treat for TB, we actually only prove the diagnosis in about 50% of cases, at most 60%. And that's a big challenge to the field, is can we derive or can we develop a TB test that doesn't rely on producing spit from the lungs?
Yes.
And there are many groups in the world working on this. We've made some really good advances at UCT. And in fact, UCT owns a patent. And we've discovered some biomarkers in the urine that can diagnose TB and can potentially serve as a screening tool for TB. And that's currently being developed and commercialized at the moment. And this would mean that one would be able to get a urine sample and do a simple test, much like a pregnancy test,
Yes.
to rapidly diagnose TB. We've taken the first step there. We do have some urine tests looking for a molecule in the urine called LAM, L-A-M. But those tests don't perform so well. So we've already started on that road. And I think things will develop from here on. And I hope that in the coming months and years, we'll have a simple test, a urine-based test or perhaps a breath-based test,
Right.
where we will be able to screen much more easily for TB. But diagnosing TB is a problem. Even if one had to go out and find the cases, it is a challenge of how to make the diagnosis, how to screen thousands of people for TB, and especially when more than half of them don't have symptoms. So these are the challenges that the world faces when it comes to TB. There's so many hurdles at every layer. And you also heard from Phumeza, the clandestine way in which this disease presents.
Yes.
Traditionally known as the consumption. It creeps up on you and you slowly become ill. Nobody knows what's going on, difficult to diagnose. So it's a completely different kettle of fish compared to COVID-19, which is much more dramatic and acute. But nevertheless, TB remains a major killer. And, these are some of the challenges that, her story highlights.
And I'd love to sort of talk about the artificial intelligence side of stuff if we have time, because I'm sure AI can play a very important role. We can get to that. But I think very important as well is understanding Goodman's experience with TB. I've asked Phumeza to tell us her story. Tell us yours.
Okay, thank you very much. As you said, my name is Goodman, Makanda, based in Kailicha. I'm an XDR TB survivor living with one lung. We have a different story to tell around when it comes to TB. My story started, I have no show any symptoms also. I was just coming from work and then I vomited blood along the road. So bear in mind, we believe in our culture when you're vomiting blood, you've been witchcraft. But because I was living with also diabetic, but I started to go to visit a private doctor. And then after private doctor, I was willing to consult the traditional healer. So when I was at the private doctor didn't find nothing with me. And then he was referring me to the clinic to go for tests for TB. And then I give out the sputum. And then it takes 3 days or 4 days, but yes. And then they said I must come back. But unfortunately, before even I go back, they go and track me on my address. And then they came to fetch me to say, I'm carrying an infectious disease. And then it come confused. What carrying infectious disease, what that means. And then I must go to see a doctor at a clinic. And then when I get there, everyone was putting a green mask, and then I didn't understand what is it, because everybody was wearing a white mask at the clinic now. I've been given a green mask, everybody's given, and the people, they are changing their faces when they're going to tell me this. And I said, no, we find out we have a TB. I said, no, I'm coming in a family history of my uncle, he did have a TB, and I know TB is a normal and can't getting cured. And then, no, the sister's trying to explain, no, it's not the TB, you know. And then I was also confused. What do you mean TB? I know. What kind of different of TB it is? And then she mentioned I'm having a MDR. And then what MDR stand for? On that time, 2013, the nurses, some of them, they don't have a clue. They just know MDR, and then they don't know what multi-drug resistant TB that means. And you sitting and confused. And then I asked them to go and call my brother so they can explain this, because they want now to take me to the a PCH, proclaim chest, where I will be locked because I'm not a right person to stay in a community. And then I fight for my rights. I said, no, I came to you to be tested, but now you're telling me I'm dangerous to my own community I've been living with. Now all of a sudden you find out I'm having this. Now I must be removed in a community, and it was a confusion. But all in all, I didn't get a treatment on that day. I must wait for a doctor. Doctor was not there for that day. They give me another day, which means I'm carrying and spreading this disease again. And I don't know where did I get it. That it was my concern. Where did I get it? Because I never have a TB before. The information they are giving me, it was, if you defaulted the first regiment of refer for it, and now you end up to MDR. And then I said, but me, I never have a TB before, and I'm not HIV positive. And you must remember, TB was associated with it, HIV. If you HIV, you must be a TB. If you have a TB, you must be HIV positive. And then I asked them to test me for HIV, but they can't find nothing. Okay, I wait for the doctor. When I get to the doctor's room, also wearing the mask, and then I must wear the mask. It's difficult now to breathe either. What I noticed, TB has really been ignored for this community. The flip chart for the medication was behind the door, which means no one cares about it. They just put the flip chart behind the door. Now, when they're going to check the medication, what must I get? They must close the door and check it, which means it was not something on their mind, like, I don't know how they operate. Okay, it's fine. I started treatment, and then I was told they're gonna give me the medication according my weight. As you can see, I was like this. I never get thin. I never get nothing. So I was getting 42 tablets a day with my diabetic. But at that time, I was still taking metformin. I think so, yes. It was 2 tablets of metformin. So they add on that medication, plus injection every day, Monday to Friday. Okay, I start on to take the medication, go on and on and on and on. So now, during this period, I think I was adhering to the treatment. Everything was going well, and then I go back to work and start working back, and then I was taking my medication. Along when I was in 20 months, I was only left with 4 months to be discharged. The treatment is for 6 years. It was for 2 years. And then the first month came back the sputum scanty, and what that means, they said, no, maybe I did something. I brushed my teeth before I give the sputum end of the month. Okay, they said, no, we can wait for the following month. The following month came the sputum now positive. Mm-hmm. The third month came the sputum positive. Now I was newly diagnosed as an XDR patient. Mm-hmm. Now, at that time, linezolid and bedaquiline, it was the time of MSF was enrolling for those drugs, and they let you sign a consent form because they don't know exactly the damage it will be done to you. But before I go to those treatment, they take me to Tigerberg. If you can go to the gate, it's a department of UWC. They're doing X-rays and whatever scan. You go in and out, and then they find out my lung was already been damaged. So the best thing was to go at Groote Schuur E16 to remove it. So it was like, okay, you don't do this, you die slowly. And I said, I already lose 2 years. Why now? I can go and do the operation. Then I came back and take the medication again to just let the lung this side to be secured. So I go, I admit myself. I remember the day on the 16th of June, I go admit myself to Groote Schuur, take a taxi straight to Groote Schuur. I don't want to hesitate. When I get there, I introduce myself, who I am, and then everything was ready for me. I would get an operation, and then I was okay, came back. When I wake up, I was already have a pot plant. I'm living with a pot plant now because MSF was arranging to having me a new regimen with the medication called meropenem. So that medication, I'm not supposed to take it through my mouth. I must use this line to go through to me. So I wake up there and I was doing well, and then I go home. Mind you, I've been in this treatment for this month, and now the injection for 6 months. They add another 3 months. Yeah. Now, I was placed in a place called Lizonobanda because I was still working, but when I knock off from work, I must go and take my punches Monday to Sunday. So it was no rest because I was at risk of losing my life. So I take the medication and everything. It went well. As you can see me today, sitting here and talking about my history, my story of what happened and what I went through in life. But all in all, I want to say, TB can be cured, but we need better resources. Like we've been with my colleague advocating for betaquelin, telemenet, and linezolid to be here in South Africa. Now we're talking about predominate. That doc, he's talking about it's a regimen for 6 months. Yes. So I think we need more focus because the TB is they treat it as a poor man disease, but it's killing millions of people without being noticed. Even as you mentioned, of if the aeroplane was crashing every day in South Africa, it will be all over in paparazzi. But every day we're burying our community members through TB, but no one talking about it. And I don't know how can I open it up and having more TB survivors to come on the platform to tell about the journey and the challenges we went through. Even during of the COVID, because I'm working with a patient, I'm a patient navigator, voluntary for the RTB. We pick up what Doc he was mentioning of the dropout of TB, and then COVID was too high. And when we go in the facility, we find out what's happening, why we don't have newly diagnosed patient, but there is a people around the community. We find out that when you come and show the symptoms of coughing and sweating and whatever, you've been tested at around the corner. You've never been sent to TB. So how many people will be affected if we ignore those cases? So that it was my story. Thank you very much.
Wow. And I think it's so important, by the way, to hear the personal stories, or else it just becomes stats. It just becomes, oh, they should do this, they should do that. But when you hear what people actually go through and you put yourself in their shoes, it becomes very different. I've heard these stories for the first time today, and it's really affected me. I've always been someone that said, we need more focus put on tuberculosis, simply because I've been in the media and I've seen the numbers, and I thought, but the stories that I have heard today, it's really deeply affected me, as I'm sure it's affected you. So, Professor Dheda, I mentioned things like artificial intelligence, and without getting too technical about AI and all those sort of things, computers can do things human beings can't. They can do things faster than human beings can, more accurately. Do you see a role for artificial intelligence in the detection of tuberculosis?
Yes, I think I definitely do. And I think just to pick up on what Goodman said and what Phumeza said, and we're going back to this whole issue of active case finding. Now, most of the very drug-resistant TB now in this country is not from people taking their drugs incorrectly. It's from transmission. It's from getting TB in churches, schools, taxis, congregate settings. So most of the drug-resistant TB is being transmitted. Now, here's the rub. By the time people self-report to clinics and hospital, most of the damage has been done. Most transmission, more than 95% has already occurred. Wow. On average, one person with active TB, by the time they present to healthcare facilities, has infected 20 other people.
Wow.
So again, we land up with this paradigm of active case finding. And the question is how to do that. How do you do that when 60% of people don't have symptoms? So the one approach is mass X-ray screening, for example. And we used to have that, 40, 50 years ago, the old X-ray vans.
Yes.
And, there's a big drive to get back to that. And where artificial intelligence, for example, comes in, is we could do portable, they're portable X-ray units, and many people can be screened. These X-rays need to be read by radiologists and very skilled people, but one could use artificial intelligence or put in lay terms, computer-assisted reading of chest X-rays.
Yes.
And there are already software programs to do this. We have got funding from the European Union to run a very large trial in 4 African countries, including in South Africa, that's going to be screening over 100,000 people. And we are using mobile X-ray units and testing this technology where the information will be uploaded into a cloud and computer systems would read this, giving a score of a high probability of TB.
Yes.
And this would mean that we would be able to pick up potentially asymptomatic people and then get them properly tested to confirm the diagnosis.
Okay.
So that's just one example. There are other examples, but it's one example of how artificial intelligence and digital health technologies are being used. It's not ready for prime time yet, but I think it's a rapidly moving field, and I think it definitely has a place because, as Phumeza pointed out and as Goodman pointed out, the issues are transmission and the issues are making the diagnosis.
Absolutely.
So I think it's not, one size fits all, but we're going to need all these technologies, urine screening tests,
Yes.
artificial intelligence, X-ray tools, sputum-based tests, non-sputum-based tests, addressing the transmission issues. And that's what comes to the fore with COVID-19, right?
Yes.
And all these things, masking, keeping windows open in taxis, better ventilation, these all apply to TB. And, this is what, all this etiquette we apply, hand sanitizing, masking everywhere, ventilation is the big thing now.
Yes.
Now actually found to be much more important than hand sanitizing and so forth. But these are the very things that are going to impact TB transmission. So we need to focus a lot more. And just like, we did for COVID-19 and are doing, we need the dashboards, that we also need all this public health advice to be applicable to TB. So, lots of things to be done.
Absolutely. And we could have this conversation for another hour, and there'd be lots to say about it. But the one thing you must remember, yes, we might be in one of the hotbeds of tuberculosis around the world, right? But we also have the best medical professionals in the world when it comes to treating this. And I think that, for me, is a huge saving grace. And that is where we're going to leave it. I want to thank Brimstone Investment Corporation Limited and Groote Schuur for making this conversation possible. So thank you very much to each and every one of you for contributing personally, professionally to this conversation. And I encourage you to share this widely. Remember what I said about the airplanes crashing. They still are, they're just silent. You can't see them, you can't hear them, but the same amount of people are dying. And you and I can work really hard to help arrest that.